I'm going to call our panelists forward. We have three from our own team here at Loma Linda University Health who are going to respond to Dr. Berlinger. And I'm going to introduce them, and then they'll speak in this order. Dr. Chris Church, who's sitting by Dr. Berlinger, is a surgeon, an ENT surgeon, and he teaches on our team for the third-year medical students, and he and I are on the same team. And I've heard him talk about how to handle medical error, and I've been so impressed with what he says that I thought it would be interesting to have him respond today. Dr. Church did his medical degree here at Loma Linda, and he did his advanced work, his fellowship at Stanford University. Next to Dr. Church is Dr. Grace Wee. Dr. Wee is in charge of our clinical ethics program for all of Loma Linda University Health. She's a pediatric intensivist, and she also has a graduate degree in ethics. She is also the associate director of the Center for Christian Bioethics here at Loma Linda, and a wonderful colleague. Finally, Chris Johnston is an attorney in our Office of General Counsel, and Chris sometimes helps us with lectures on ethics for our medical students. He is a graduate, took his law degree at Pepperdine University. So I think we'll go in that order. As we read, we'll start with Dr. Church, then Dr. Wee, and Chris Johnston gets to wrap it up. And after you've talked a bit, Dr. Berlinger can respond to that. And then we're going to let you send text to this. You can start doing that whenever you like. Corrections, questions, comments, whatever you'd like to send. And I'm hoping this technology works. So give it a try. All right. Dr. Church.
All right, I guess I get to lead off. I am probably the only person up here who's not actually an ethicist. I joke that my role with the medical students is to serve as clinical fodder and offer up my confessions to them on a regular basis and let them judge me. One of the first thing I want to say is that I can highly recommend Dr. Berlinger's book, After Harm. I don't know if I liked it, but I did find it very interesting, and I would recommend it to you. And I don't mean that I disliked it, but I did find that for a fairly short book, it was very difficult for me to get through, because after nearly every page, I'd find myself distracted by my reactions, positive, negative, or stories that came up. And it took me forever to read this really short book. But I would definitely recommend it. I brought it for her to sign so she can absolve me. One of my roles here, in addition to helping with the ethics session for the third years, is being part of the admissions process, both for the medical school and I am the residency director for ENT, in deciding who our next doctor is going to be. And when you look at these issues in terms of error, I find it a little bit challenging, in the sense that I am an advocate for our profession. I think that it's still a terrific career. And I routinely have young people that will come to me before application and say, do you like what you do? Should I become a doctor? And my answer is almost inevitably yes. I think this is a fantastic profession, and no matter what, economic or systems changes occur in our profession, until they take away that sacred doctor-patient interaction that I feel so humbled to be part of every day, this is the best thing I can imagine doing. And yet, the line of thinking is that, okay, realize what you're asking for. To err is human, you are human, therefore you will commit error. And then the next part is, and therefore you must suffer. And there will be maybe quote-unquote forgiveness, but there is no absolution. And you will wear the cumulative effect of your errors throughout your career, till the place that when you retire, you will either have figured out how to deal with these or will be a broken person. And so this is challenging. And if I say to them, oh, come on, join up, you're going to love doing this, but I don't disclose that this is part of what we live with, I don't know if that's being entirely honest. The other thing that I do is I deal with my residents, and I won't ask for a show of hands, but I'm pretty sure that all of us made a lot of mistakes during our training. And how do we, as their mentors, help them deal with this in a healthful manner? And, you know, I certainly wish they would read the book or hear the lecture that we just heard in a way of looking at us in the way that we can experience recovery ourselves, and at the same time continue to put our patients first in these interactions. And, you know, I can think of shortly after I assumed the role of residency director, went out for dinner here at Panera down here at just, you know, a mile from here, and happened to see one of my residents sitting in the corner weeping. And I went over, and, you know, she was in her last year of residency and had transected a facial nerve in an ear case that day. And what do you say? I wasn't prepared 10 years ago to know what to say that would appropriately comfort her. And even today, I'm not sure I'd know what to say, because we have this thing that says, I don't want to forgive you for this in a sense, to tell you that it doesn't matter or it's no big deal. I want you to learn from this. And at the same time, you know, obviously I know that you're hurting, and I need you both from a practical sense and for your own good to get back on the horse and be able to function tomorrow. I don't remember what I told her. I think I probably had shared an experience where I had done something similar. And anyway, so sometimes these things bring up more questions than answers, but those are the things that I think of when I hear these. When I heard you talking. Thank you. That was terrific.
Thank you so much, Dr. Berlinger, for such an excellent topic. And I'm not as eloquent as you, Dr. Tur, so I actually wrote some notes down, because I don't have the ability to just form paragraphs and sentences and off the cuff. But I am about to disclose something now, so I hope, Chris, that you're still going to be supportive of me.
I don't know yet.
Great lawyer response.
But I go next.
But as a physician, I have made errors in the course of providing patient care. And some of the errors I have made have had deep consequences for the patient and for myself. And I always strive to live up to the ethical obligations that medical error imposes. And these obligations, they're hard work. They're hard work to meet. This morning, I wanted to share a personal aspect of this work, and just to talk a little bit more about self-forgiveness. You know, as a physician, Dr. Berlinger, you really pointed out, what does it mean to forgive when an essential part of your job is to continue making decisions that will affect the lives of patients? And of course, part of the work is improving the system around the decision maker, building in safety mechanisms, improving the decision maker's own knowledge base. But what I'm referring to is, how can the physician, how can I find the courage to continue the practice of medicine when the reality is that I not only made mistakes in the past, but I will continue to make mistakes in the future? Shouldn't I quit now before I harm any more patients? Personally, I am deeply committed to the idea that a core essential of physicianship is walking the illness journey with the patient. This journey deepens the patient-physician relationship, and this relationship forms the moral basis of how I, as a physician, can advocate for my patient. How then do I endorse a recommendation for my next patient when my actions have harmed the last patient? Forgiveness of oneself is not cheap, and it should not be, nor should it be easy. There is no cheap grace when forgiving oneself. This sort of work should change you. It is long, it's messy, it's a journey. But personally, I found a measure of forgiveness, self-forgiveness, through exploring what it means to love mercy, and to walk humbly before God. I would love to spur on more of a conversation about this, but I just want to take a few more moments to mention how I've used and I continue to use the power of intention to experience this intersection of humility and mercy. And the mercy that I mention is the most expensive form of grace, and that is the one that God gives us. In my experience, I use 4 intention statements to help me to be accountable and through accountability to accept mercy. I believe that these statements help me fulfill my obligation following error. And these are my statements. I intend to be open and honest about this experience. I intend to listen. I intend to acknowledge what I don't know, and I intend to learn. And I bring these intention statements into reviewing and processing the experience that included the error in the past. And then I bring these intention statements into the new relationship that I'm forming with my patient. Thus, I am trying to bring the same thread of humility and mercy from the past into the present. And I feel that this dependence on humility with its attendant gift of mercy allows me to practice forgiveness for myself and to continue to practice medicine, even knowing that I will continue to make mistakes in the future. Now, Dr. Berlinger, I loved how you brought up how forgiveness, a meaning of forgiveness can also be detachment. And I think part of the ongoing conversation is how much detachment should occur from forgiving or the process of forgiving oneself. And I look forward to more conversation.
Thank you for your presentation, Dr. Berlinger. I'm the lawyer on the end. This is the DMZ between us. So that's the makeup here. I have a few observations, and I am not a healthcare provider, as you can tell just by looking at me. But I will speak from the perspective of one who is in the business of defending healthcare providers after something has gone wrong, as well as a consumer of healthcare. The first point I'd like to make is just as you made the point about forgiveness being personal to the individual, so must apology, I believe. And in many areas, including healthcare, there is this propensity to apologize for the wrongs of others. In the idea of apology for a healthcare provider, what you're sorry for must be something that you had the control over, I think. You may be sorry that something happened to someone, but when you're talking about the apology and forgiveness, the apology, I think, has to be personal to that healthcare provider. So I cannot say, boy, I'm really sorry that Dr. Wee caused harm or committed an error. That apology would need to come from the doctor that's involved. Secondly, the idea of apology or disclosure as, and this is in my world, as an admission of liability. And it'll get to my third point about apology limiting liability exposure. Apology as an admission of liability should not exist. You should be able to apologize because you're sorry and not ever have to worry about it. But in my world, I've seen it thrown back at people. A get well card from a physician to her patient who's in the hospital following an error, where that get well card is offered into evidence in the malpractice trial following that care. Certainly not what the intention of that get well card was. It was a good gesture, and it was heartfelt. Certainly not what was intended there. But once attorneys get involved, these things can take on a life of their own. Which brings me to my third point, and that is something that I did not hear you say, Dr. Berlinger, which I was happy for, because then I can say, this is what she did not say, rather than, here's what she said, and I think she's wrong. And that is what a lot of people, a number of people have talked about disclosure in healthcare, disclosure of medical error, as a way of limiting one's liability. if you will apologize and reconcile, they won't sue you. In my world, that's just not true. You're not going to prevent a lawsuit by apologizing to somebody. And if your reason for apologizing is to prevent being sued, then your reason is probably wrong too. If you're going to apologize, you should apologize because you're sorry for something that you had some control over or that you did, not based on, I'm going to control my liability because I have apologized or somebody told me this is how to manage my liability. I don't think that's, I'll defer to the ethicist, but I don't even think that's ethical to use apology that way. And then as part of that, I actually have a favorite jury instruction. These are the instructions that judges read to the jurors at the end of cases. This is a malpractice jury instruction. It's for those of you that, okay, none of you probably read these things. But if you did, it would be CASI 505. And what it says is, a physician is not necessarily negligent just because that physician's efforts are unsuccessful or that physician makes an error that was reasonable under the circumstances. So even admitting to or apologizing or having experienced an error does not equate to legal liability, does not equate to negligence. That's one of the reasons it's my favorite jury instruction, because even the law says you don't have to be perfect. Some of you think that, but the law doesn't do that to you. You do it to yourselves. If you look in your wallet, if you carry it there, or in your glove compartment, there's probably a card in there that, or there should be, that evidences your automobile liability insurance. And if you read that, there's likely a number to call in case of an accident. But there's also usually a statement on there that says, in case of an accident, do not admit fault or do not admit liability. I used to get questions about that. Well, I ran into somebody. Of course I'm at fault. Why can't I just say that? We both know it. They were stopped. I was texting. I ran into them. I know it. Here's my answer to that, and it goes to one of your slides that says, do not speculate. When we admit to something, we don't always know what we are admitting to. And a good example of this, even in the auto accident case, I was working on an accident where it was a very slow, two cars stopped at a stop sign. The car number 2 foot slipped off the brake, rolled into the car in front. 5-mile-an-hour collision. Little crease on the bumper. That was the damage. The admission of liability was, this is all my fault. I will take care of it. I have good insurance. Don't worry. Right? What the individual making that admission was saying was, I'm going to pay for that creased bumper, or my insurance company will. The lawsuit alleged that 5-mile-an-hour collision resulted in a miscarriage. Now, I know a lot of you are saying, well, there's no way that's true, but defending a lawsuit costs a lot more than buying a new bumper. Defending a lawsuit with everything that's happened here, all this sequelae from this is my fault, also takes a little more time and resources. So I agree with the statement, don't speculate, don't blame, stick to the facts, and as a physician that is making that disclosure, as your consumer, as the patient on the other end, what I want to hear is what happened, how does it affect my care, and what do we do now? What is it? You're my doctor, you know what I need to do now to fix this. That's what I want to know. Now, it may be that a lawyer gets involved and decides, well, in addition to that, let's sue him. But right now, in that meeting, I don't need to know about anything other than how do we get me or my family member past this error.
This texting business actually works, so, and many of you have taken advantage of it. It's a rich opportunity, thanks to all four of you, surgeon, physician, lawyer, and a philosopher, theologian. Rich opportunity to get some questions answered that you may have been thinking about for a long time. And many of you have asked, and by the way, somebody asked, can we put up those resources again instead of this number? And we'll do that right at the end, but I'll leave the number up for now. We'll put the bibliography back up. So, of course, somebody was wanting to ask, what are the legal ramifications of telling a patient, I'm sorry? And you've just addressed that, Chris Johnston, but does anyone want to add to that? Or do you want to correct anything?
I think it might be helpful just in response to this question to maybe perhaps say a little bit about I'm sorry laws.
So there's first, whatever law that we're applying is going to vary from state to state. Malpractice cases are going to be different in various states. So certain jurisdictions may say it doesn't have any legal significance, or if it's part of a settlement, this is how California does it, if it's part of settlement discussions within a litigated case or a potential claim, then it's not subsequently admissible as evidence. The example I brought up of the get well card, there was certainly good reason to try to exclude that from evidence. Tactically at trial, it was so distasteful, we figured to the jury that somebody would take a get well card, and the attorney, and throw it in somebody's face, that we let it come into evidence and then threw it right back. But that's trial tactics. The point is that sometimes, even when there may be legal protection for apology or during a settlement discussion, it takes on a different life during trial. I went to a mediation one time, or many times, but the one time I'm thinking of, where we sat down on mediation and the opening statement from plaintiff's attorney was a 20-minute discourse about how this lawsuit was only about apology. Was the only thing we ever wanted was for somebody to say, I'm sorry. And we're here today because that's all we want. And as soon as he stopped talking, I looked him in the eye and I said, I'm sorry. Then he said, of course, we need to talk about money too. But the point there, other than he was disingenuous for 20 minutes of my time, is that once lawyers get involved, even the lawsuit's not the way to obtain the apology, even though they might justify it. Or I'm not going to sue Dr. Church. Oh, don't worry, you don't have to sue Dr. Church. You're just suing his insurance company. Dr. Church's insurance company is not going to be on the caption of that lawsuit. Dr. Church's name is going to be there.
Anyone else want to add to that,
Can I say
Chris?
something about that? Yeah, I mean, the challenge is how do we follow up apology with the appropriate response, which is appropriate compensation, without entering into an adversarial relationship. So there have been times wherein we'll say, you know what, I made a mistake, my team made a mistake, the system made a mistake, this person's been injured. I would like to try to make this right without having to, and the response sometimes from our risk management professionals is, no, you need to wait, and basically force them to sue us. And that is, Chris may accuse me of mischaracterization,
I'm about to.
But that is kind of the vibe I get from my risk management people when I've approached them with this. Now, that's not every time, and sometimes it's probably my own ignorance that has, is the problem. And I have been, chastised and educated by our own lawyers at times. I don't want to give you the impression I do this a lot, but we want closure. We want to make things right with the patient, and I understand that maybe that means that they don't have to pay for this or that they get this extra service or whatever, but we're really not the experts at that, and yet that's kind of where we're at. So, okay, straighten me out.
Happily. So that risk management forces anyone to sue is inaccurate. What I think you're really saying, and you can correct me, or you can, no, don't correct me. What I think you're really saying is, I want this fixed right now. The risk management response is, if somebody has made a claim against you for malpractice, we're going to look into it, we're going to investigate it completely. We might even have to ask, even though you think you made an error, we're going to find some other surgeon in your field to review your care and tell us whether or not the care you provided fell below the standard of care. I mean, you're a surgeon, so you have patients work through informed consent with you, and you say things in there like damage to surrounding tissue. You don't say that because you plan to damage surrounding tissue necessarily or unnecessarily, but because even when you do something right, sometimes things happen that you don't want to happen. So the risk management response is deliberate and slower than a lot of healthcare providers want. But that does, and during that process, it may be that somebody sues you. But it also may be that during that time, before that running of the statute of limitation, there is the opportunity to resolve it financially through compensation, which we have done here. Apparently we haven't done that with your cases, but.
Thankfully, we haven't had to go that far, but there, you know, when I read, you know, Dr. Berlinger's book, and we know of proactive systems, the Lexington model, others, that physicians say, well, that looks great as a way of achieving, maybe rapid is unrealistic, wholeness for my patient, and a best possible outcome for the situation. Yet I don't know that I can totally divorce myself from my desire to get personal closure on that, you know, and we certainly recognize the importance of thoroughness, and that's often not what I want, and certainly often not what the patient or their family want.
Yeah, the other part of that is that even where we have determined that, yes, Dr. Church was negligent, we need to compensate this patient. Let's say we're going to admit liability in this case. We're not even going to try that. The idea of what is actually fair often varies significantly, to the tune sometimes of several $1 million. What is fair compensation? Even what you might think is fair, you might say, well, they should have we should compensate them for their lost wages, their time off work, the cost of subsequent surgery, and then you realize, which would come to $60,000, $70,000, and you get a demand that says $10 million. And so it may be that we're not able to even through negotiation bring that to an understanding, not because risk management is opposed to resolving it earlier, or it's just a different concept of fairness. But even so, we have had cases that have been settled short of the lawsuit.
Let me, I'm going to put Dr. Berlinger on the spot for a moment. You talked some about self-forgiveness, and of course the whole issue of apologies now been addressed, and we'll keep talking about it. But what about a case, I'm going to tell you a story just to illustrate it. One of the first cases that came up to me back in the late 1980s when I first came to Loma Linda involved a 12-year-old boy who had his leg amputated because of a diagnosis of osteogenic sarcoma. And when he came here, the people here studied his medical records and concluded actually he never had osteogenic sarcoma. In fact, had a tumor that should have been resectable. And the question that came to me as the ethicist is, okay, remembering this is back in the 80s, do we tell? I have to say that over the years, that used to split the audience. If I brought it up to medical students, it doesn't anymore, because I think the assumption is that you're going to tell. Yeah. But knowing that if we tell, that work was done a couple hundred miles from here by people not connected to us at all. He had moved here and was here for follow-up care. So do we tell on somebody else and then apologize for what they had done? It was a complicated situation, to say the least. I'd like to hear your comment and the comment of any of the others.
Well, that exact scenario came up. I remember I used to do grand rounds with orthopedic surgeons, and this is exactly what they would say, because they would say, well, people come to us for one reason, they're in pain. And sometimes when we look at their medical record or what has been done, we see misdiagnoses or procedures that cause more harm than good. And sometimes we know the practitioner. Sometimes it's somebody in our general area, but sometimes it isn't. So they were wrestling with this. This was a long time ago. But I think today you would say, well, of course you have to tell, if only because the patient deserves the truth about what is going on in their body. A child, especially going forward, to say there's a big difference between saying that you have a cancer history and that you don't have a cancer history. But I think part of it is a disclosure. It's truth-telling, the foundational, that's how we respect others. The apology is more challenging, since you actually, in a way, you caught, you caught the problem after something terrible had happened. But you said, okay, we're not going to continue down the track of assuming that you're a post-cancer patient here. But I don't think it's disclosure, but apology, but it's a very enriched form of disclosure. You're going to be saying, there's a truth about yourself that you did not know. There's a truth about your child that you did not know. There may well be a reason. I always remember Carol Bailey, who used to be up at Catholic Healthcare, not Catholic Healthcare West, and then it became Dignity. She would say sometimes, she and her risk manager and her lawyer in that system came up with these sort of working principles for cases where something had gone wrong. And they said, sometimes we do advise a patient, you should seek legal counsel. Now, I'm not saying that would be exactly what you should do in this case, but she said, mindful of the fact that the hospital always has a lawyer, for example, has a whole legal department. But sometimes a patient is they're only going to be able to suss out something. They're not saying you should lawyer up or passing somebody a card or something like that, but this is something that they are going to have to explore. But that is an interesting question: is how far do you actually sort of case manage this? I don't know. The other difficulty is there could be continuing medical costs as the result of that harm that weren't on you, so to speak, but they're on your system now. So I think that this benefits from an interdisciplinary response.
Part of that question, too, I'm thinking about is whether we had an obligation to contact the caregivers who provided the original work.
I would think you would have to.
Yeah,
Would you
think.
not?
Yeah.
I mean, don't you in normal cases confer with previous providers sometimes? I mean, if you have a patient and someone used to be your patient and there might be something missing in the medical record or something like that. So, it is. I'd love to hear from my clinical colleagues. But I think it's clear that disclosure. But there's two ways that I'm sorry works, and one is as an acknowledgement of sympathy. What happened? I am sorry that this happened to you. But in this case, you may be also disclosing you didn't even know this happened to you, or your narrative is different from the narrative you thought you had.
I think part of the complexity that we were feeling is you're really disclosing for somebody else. Let's see what the others say.
Well, I think one of the difficulties is that this disclosure opens up a breach of trust between yourself and the patient, and now it's incumbent on you to do all the hard work to repair that breach going forward. There are a lot of complicated feelings that go along with that. And it is tempting to say, as part of as part of restoring trust with your patient, it's a little tempting to say, well, so-and-so, or this, or,
Right.
yeah, is that fair?
It would be very, and in cases like that, whether or not you knew who the other provider was, you don't have the whole story. All you know is that you've got a wrong diagnosis, but you don't know if there were other providers. There's so much you don't know there, but that would be quite the, because that's absolutely right. It's both risk management in the sense of it, even if there weren't a legal reason why you had a claim against this system, there is still, you've opened a very risky terrain when you're saying, something, there was a misdiagnosis here and a completely wrong plan of care. And as you say, I am still your child's doctor, but you may now be looking at me as wow, I've just given you terrible news here. In a sense, good news, your child never had cancer, but there was no need for the procedure. This would be quite a case.
So, two of you teach medical students at least. Well, I guess quite a few people here teach medical students. Here's the question: how do you prepare medical students for the reality that they are likely to make some kind of error in their career? And let me just add to that. I read the third-year medical students' papers, as you do, Dr. Wee, and it's not unusual for them to describe a situation in which they feel caught in the middle because they've seen something, but they're not really in charge of it. And then maybe it didn't follow all the principles we just talked about, and they don't know what to do about that. So it's really kind of a mixed question on preparing students in what you tell them, but also in what gets exhibited by way of example. Any comments on that?
I actually, I did it this morning before coming here. I do a session for our third-year medical students, resiliency and death and dying. And so when I was asked to talk about resiliency, especially around death and dying, intuitively, I also wanted to include feelings of guilt or shame or just very negative feelings that can come about because of decisions that you make. I think the decisions, or excuse me, the deaths that really haunt us the most are the deaths of patients in which we've had a direct hand or a participation in their medical care. So I tell them stories of very difficult things that have happened to me, and then I share with them my own tools that I use. So, the intention statements, I use that a lot to unpack these experiences. I try to help students understand the importance of developing empathy for the other people in the scenario, the patient, the family, the nursing staff, et cetera. And then I think the last thing that I want to share with the medical students is to be aware of negative feelings that can really block successful exploration and unpacking of these difficult circumstances. I mean, I think you'd really, I love that analogy of having a bad experience, in this little ball, and then every time you push it away, there's another layer, it's like a callus that grows on it. It becomes harder and harder and harder to actually unpack it and to open it up. And it becomes this festering abscess. And I want students to be aware of the negative emotions that are brought up when you talk about a difficult experience, especially related to error, and to be able to have the courage to face it.
While you still have the microphone, great. Oh, by the way, sound check. Are they close enough to the microphone so you're hearing that okay in the back? It's okay? All right, good. Somebody wanted you to repeat the 4 intentions, just came in.
Oh, okay, thank you. So the first intention is I intend to be open and honest about my experience. The second one is I intend to listen. I intend to acknowledge what I don't know, and I intend to learn.
Here's a question for any one of you. Are there ever times when an apology adds to harm rather than alleviating harm? Are there ways in which the doctor focusing more on herself or himself than the patient in the apology? There's more about, I suppose, the question has to do more about the feelings of the physician.
Well, I think that part of it is that the phrase "I'm sorry" in English can mean I'm sorry about this bad. I'm sorry the chemotherapy didn't work. That isn't a fault admitting apology. That's an expression of sympathy. Didn't mean it was the wrong drug or whatever it may be, but and sometimes we do need to reach for idioms that say, I am sorry that this happened to you. I think where we get in knots are when we try these, I acknowledge that this bad thing happened that I had nothing to do with. It gets very false sounding, and people pick up on that right away. Sometimes I don't think that. I mean, a doctor can feel. I've seen doctors break bad news, and they're clearly shattered. Maybe because they've been identifying with the patient, same age, or they've had this patient for a long time. I think it's hard for a patient when that doctor becomes very clinical all of a sudden and saying, wait, you were so warm when the results were good, and now where am I? So I think patients, it's hard. Patients, I've been in that caregiver role, I've been a patient, you want that doctor to be human, and you also want them to save you. It's very, I'm not a clinician. It must be very hard to be a clinician and to hold those two, to be human and to be competent at the same time, but I think apart from getting out ahead of something, because there's a possibility that one could over apologize for every single thing before it's clear what actually happened. And I think the team concept and the system concept makes that difficult when you're still figuring out what the problem was. I mean, so often it is something related to the pressures of the healthcare system. That wasn't labeled properly. We were very rushed that day. I mean, there are things like that. And when I talk about those in the workarounds, where sometimes normal situations occur under pressure, and then you happen to be the person on the spot when it goes wrong, when it breaks. So it's hard to convey that in a personal apology. But I also agree with my clinician colleagues that you're human. You have to be able to. I mean, you walk around with these. Some of the things that have resonated with me is when a doctor stands up and said, I was a third-year resident. It was 4 a.m. I was in the ED. Here's what happened, and it has never left them. So sharing that as a mentor is really important, even if back then there was no possibility of telling the patient or apologizing to the patient. The norms were different. But witnessing, here's what I wanted to say, even though I was told not to say it, or it didn't occur to me, I didn't have the words, is very important.
A question about comparisons. How have you dealt with the comparisons that one almost automatically makes, comparing oneself with his or her colleagues after making errors, especially if it isn't the first time the error or mistake occurred? That would probably require an unusual element of self-disclosure, so you can take a pass on that, but somebody wanted to ask that question.
I think this is commonly called imposter syndrome. And I think it's very common to feel this. I think if you've really done, the real work associated with forgiving yourself, you come to a point, or forgiving others, you come to a point where there's the choice to have compassion and to practice loving kindness towards yourself and also for others. And practically, what does that mean to practice compassion or loving kindness? And this is a work in progress. I mean, I love dialogue about this because I want to more fully understand that. But for me right now, it's, did you do the best you could with the information you had and the tools that you had at that time? Not the information that you have now, not the tools that you have now, but at that time and place, did you do the best you could? And if you did the best you could, how can you ask anything more of yourself? How could you ask anything more of your colleague who did the best they could with the information they had, with the tools that they had?
The challenge with that, Grace, is how often do we really do the best we could? And when I look back on it, even if I, at the moment, thought I was doing the best I could, I always find room for, I should have studied more in advance. I should have practiced more for that procedure. I should have been more attentive. Hindsight is better than 2020. It's terrible. But you know, I don't know. That's not an easy thing. I think that you can't help but compare yourself to others. There are no other standards. This brings us to our one ritual for this, which is the M&M. And there are good M&Ms and there are bad M&Ms. And I've been part of all of them. And there are many others in the spectrum that I have not been exposed to, but y'all can look at your own experience. A good M&M allows you to compare yourself to the standard and is going to, in the end, make you and everyone else who hears the mistake better for the conversation and will help people in the future. And of course, the bad M&M is going to be basically makes you just feel smaller and smaller. The first time that I created a brain fluid leak in sinus surgery during my fellowship, I had to stand up in front of a hospital staff that I was not raised by in my fellowship and have my mentor show my error on video and a loop over and over the whole time I talked. And this is one of the more caring doctors I've ever worked with. You know, there's always room for improvement in that. But yeah, that's a terrific question.
If I could speak to it, first, I've never made a medical error. I want to disclose that to all of you. But, and I hesitate to speak just because why would the lawyer be picking the doctors up on this issue? But the law actually speaks to this. And I referenced one jury instruction. The next one in sequence, in case you decide after this that that's what you want to do tonight, is read jury instructions. Talks about alternative methods of care. And when we're looking at legal liability, what that jury instruction says to your jury that's going to decide this is, if you chose one method of care and that was different than what somebody else would have chosen, you're not necessarily wrong, even if what they would have done would have been a better thing to do, so long as what you did was reasonable under the circumstances. So as you compare yourself to each other, and I'm sure you do, at least the law says you don't all have to be the same and do everything the same all the time.
You know,
That's second to being perfect. You don't have to be perfect. You don't have to be the same. You're welcome.
Thank you.
Thank you for that.
Let's hug our lawyers today. There's a couple of them right up there.
While you're getting ready to do that, but remember there's a virus going around.
So really hug your lawyers.
There is a national and an international Hug Your Lawyer Day, and I will provide shirts if you want them.
Actually, Jerry, I just want to really quickly respond. Dr. Church, you said, when are we ever doing our best? Yeah, that's a really tough question, and I'm not wanting to say that the question, did you do your best with the tools that you had and the knowledge you had? It doesn't absolve you from the responsibility that occurs from an error having been committed. But I think practicing compassion and loving kindness to yourself actually helps you to be able to take responsibility for the obligations that are incurred afterwards.
This, I don't know if this was written by an attorney or not, but it has that sort of feel, and it's actually a little bit long, but and there's a question near the end of it, but I think I'm just going to read it as it is here and see how you respond. The discussion proceeds largely on the assumption that medical harm is the result of physician malpractice, failure to comply with what is known as a standard of care. Many of us in the trenches who deal with the legal after effects of adverse events find that adverse events are overwhelmingly not the result of wrongdoing. They do not and should not arouse guilt in the provider. Physicians do not guarantee the desired outcome. Isn't it vital to make a distinction between harmful outcomes that are simply risks inherent in the procedure or complications related to the underlying conditions and outcomes which result from true failures to comply with the standard of care? Imposing the therapeutic religious model on all adverse outcomes seems likely to arouse false guilt. Anyway.
Well, it is not that clean. There is a spectrum here. There are errors and there are errors. There are mistakes and there are mistakes. And it isn't as simple as you screwed up in this case and this is just a bad outcome in this one. And I will tell you that I think that it's hard because even in the ones where you look back on it and you say, there is no way I could have suspected that that was going on in that patient. I did everything I knew to do right. I gave maximal effort, and I still feel guilty. And maybe that's my own, maybe I need to talk to those 2 psychiatrists we had earlier this morning, but I cannot help that. And I think that it's a good question, but I think his life is a little messier than that.
Yeah, I think when I was conceptualizing this book, that I think that's exactly the kind of clinician insight that maybe call it not after adverse events or after mistakes, but after harm. There's that consequence of not just, oh, I could have done better, but I actually hurt someone I was trying to help, or my actions contributed to harm. And my foundational principle is meant to be do no harm. And there is a real problem. I'm having real trouble living with that. Even if I've been absolved in many, many ways, I still am going to have to come to terms with that. And we would not want a professional to say, well, don't worry, there's a simple explanation for that. I rationalized that. And it never rings true to clinicians. They really do carry those feelings with them.
We also need to understand that we make the systems. The systems aren't just formed and then we work within them. We actually make them. And so if it's a systems error, ultimately it's still our responsibility.
This looks to me like it may have come from a medical student. Most medical students don't get into medical school by making mistakes. I find one of the most challenging experiences they face is how to work through failures. Attendings, sometimes chief residents, make this issue worse. Can you describe a healthier way for attendings, residents, to provide healthier support and modeling? Any medical student want to raise your hand? Anyway, have a crack at that.
Thank you to that for that question, which and it might not have come if a person was in the room. That may have been something that a person needed to do anonymously. A great question.
Yeah. Crickets.
Everybody's looking at me. Yeah, I think that many of us were raised in a less kind era. And I think what Grace has been talking about in terms of self-forgiveness was not something that I was taught. And I'm a little older than I look, but I'm not that old. I think we're still learning, whoever wrote that. And I hope that as time goes by, we model better ways in our own lives of how we deal with these things and self-forgive. Medicine today is not the hostile landscape that it once was, whether it's duty hours, whether it's student and resident abuse. It's certainly a much kinder and gentler place, and there are people here who may have opinions about that. But it's getting through errors is never going to be easy, and we owe it to you as learners to hold you accountable. And yet at the same time, you must understand and have mercy on us that it's difficult to do that and yet be kind in the process.
I'm already getting ready to offer an apology of my own because I can see that there are a lot of great questions here that we won't have time to get to. But I do promise you this, we will share them with the presenters here so they at least know what you were thinking about, and I will encourage you to continue talking among yourselves after we're needing to finish. But here's one that's, it takes just a moment to read, but since it mentions nurses, and since I've spent nearly 54 years married to one, I may have a nursing perspective on some of this, and they haven't been mentioned much here today. So. We had a patient with multiple very bad orthopedic injuries and terrible head injury, comatose for at least a week, severe pulmonary problems, abdominal problems that had multiple debridements of extremities with worsening circulation in the legs that had the patient survived would have needed to be amputated. None of his sepsis seemed to be related to his orthopedic injuries, confirmed by 4 orthopedic providers. I'm getting a sense of who may have written this. The patient died with severe sepsis. The nurses blamed the orthopedic surgeons, and the intensivists made it sound like we were responsible. Whose truth-telling do we believe? Well, I think the nature of the question is that in an environment that is quite complicated as to who's the authority, and we have many teams working, and let me just say a word for at least the nurse I've worked with, they often feel caught in the middle of a lot of this, and trying to, because they're there through the whole thing, while other people come and go, and often kind of end up in almost a mediatorial kind of role. Anybody want to comment on, there's a lot going on there, but whose truth gets told, and since they raised the issue of nurses, I'll just put that on the table.
You know, I just want to briefly say that nobody ever goes into medicine, no clinician, nurse, physician, respiratory therapist, you know, nobody ever goes into medicine with an intention of harming people. You know, everybody's there for a really noble reason, and that is really to help the patients, and to help patients to the best of their ability. And I kind of want to put another plug in for compassion and loving kindness, because in order to really do the hard work, I think, of forgiving yourself, you have to be in a place of psychological safety. You have to be in a place, you're going to be in a place of vulnerability. You're opening up yourself, and you have to be open and vulnerable in order to receive mercy. And we ourselves have to be open and vulnerable in order to give mercy to other people. So if we approach difficult situations with the intention and the mindset that everybody's there trying to do the best thing, but something terrible happened, but everybody is just really trying hard, it becomes, I think, a little bit easier for us to start accepting our own sources of responsibility instead of trying to blame other people. I mean, I don't know, that's just my personal feeling, having been a part of very complicated, bad outcomes. It's always been easier for me to work through it when I feel like other people are wanting to be merciful towards me.
Just to echo something that Grace said, I absolutely do not believe that an apology or disclosure requires assignment of blame. And Dr. Berlinger, I think one of your third or fourth slide had a quote to that point. Often people are maybe looking for that, but that is not, I don't think that is a requirement.
It also sounds like in this case, which was a very medically complex case, a lot of, I once asked, you know, in a case of a patient like this, you know, how many people would be involved? And somebody said, about 200, you know, if you count all the shifts over a month or something like that. And so it's not, you know, 5 people, the nurse, the surgeon, the physician of record. And a point I once learned from a nurse, I used to teach postgraduate nurses, and one made the point that nurses and doctors are still socialized separately, educated separately, and then thrown in together and told they have to be a team. And that's really hard, you know, and in the ICU, they're very close. And so you see these, and the power dynamics are real, you know, in terms of how you ought to, you know, who should defer to whom and who makes what decision and so on. So that's something I think we have to work on outside of these sentinel events, outside of these crisis situations, to say, how can we actually help people to think and learn and support each other in everyday practice when they're working together. So because then when you have a crisis like this, then you're looking for the other, you know, and when we do that, we look for an other to blame. But if perhaps there is some way of saying, this is how we work together, this is how we support each other, and we are all should have fidelity to that patient, even if we have many misgivings about the route by which this patient got here. You know, maybe there was, this was a patient who was transferred, maybe there was a history of poor care. It's really hard sometimes. You can't make up for it all, but you can figure out how to work with each other in a compassionate way, but also a very pragmatic way, because all of this is happening in real time.
Probably a good note to end on. I know that the schedule allows us to go a little longer, but some of you have other meetings, and I'm going to hear the keys jingling soon. So thank you all for coming, and we will put the slide with the resources up there. And shouldn't we thank these fine presenters?